1 second. Can you guys see the slide?
Yep. Can you put them in slide mode? Perfect.
Here we go.
Excellent. Oops, that's presenter mode. Can we take up, or can we do regular slide mode?
Mm-hmm. One second. I think we can do this. Can you still see it, or like it's still invisible?
I see this. I see the slides,
Here
but
we
it's
go.
not in slide mode. Let's try one more time. Otherwise,
How about this?
You got it.
One more click. I think it's perfect. So these are a couple of disclosures for things that I do that are unrelated to our Vietnam project. Next slide. So I'm excited today to get to share the work of our team. Our objectives are to define global oncology and describe implementation science as a framework for improving outcomes in low and middle income or LMIC countries, to describe current pediatric bone marrow transplantation in Vietnam, and to describe the use of an interprofessional implementation science approach to improve bone marrow transplant infrastructure in Vietnam. Next slide. Okay, go ahead. Okay, so what is global oncology? This is a growing area and is actually becoming a recognized area within academia. Global oncology collaboratively addresses disparities and differences in cancer prevention, care, research, and education, and the disease's social and human impact around the world. It includes a full spectrum of activities ranging from epidemiology to implementation science to public health policy. Next slide. How do we think about this at UCSF? So one of the hats I wear is Associate Director of the Global Oncology Program in the Cancer Center. And we've thought long and hard about this. And when do we push and when do we pull? And what does push-pull mean in terms of approach to global oncology? As individuals in academic medicine, there are some traditional benchmarks, grants, transparent communication, adhering to ethical standards, shared core values, and reciprocity in opportunities for early career investigators. At the same time, we don't want to have a global oncology model where we simply push everything that we do here onto our partners in another country. Instead, we really want to collaborate them and to help pull them up to the more advanced standards and improved outcomes for patients. And that includes really focusing on what are the research priorities in their setting as the colleagues in country perceive them, capacity building activities, education, mentoring, and professional development, working with their colleagues in country in terms of who should get trained, what are their knowledge gaps, and what resources are needed to fill these gaps. And so in this push category are really what we think of as non-negotiable from the global oncology program in the Cancer Center. And in the pull category are the areas where our partners are in the driver's seat and we really play a supporting role. And hopefully as we go through this and then at the end we can maybe discuss this, we can demonstrate to you how we've really thought about this in terms of the work we're doing in Vietnam. Next slide. As a pediatric oncologist, you always have to show this slide. And it really does, I think, show how clinical trials have dramatically improved the outcome for our patients over time. And so in the 1960s, leukemia in a child was almost uniformly fatal. And each of these lines on the survival curve actually represent outcomes in subsequent clinical trials. And currently in the United States and in most other developed settings, we're able to cure almost 90% of children who walk through the door with leukemia. And it's important to note that those cures come with traditional chemotherapy and don't include CAR T cells or BiTE antibodies or targeted inhibitors. that we use, but really just traditional chemotherapies that are actually on the WHO, World Health Organization's essential medicine list. So next slide. So what does this look like in developing settings? Our philosophy is that all kids deserve access to high quality care. Children don't choose where they are born. And so what does this look like in developing countries? So the incidence of pediatric cancer is poorly understood. The registries in most developing countries are still limited. It's believed that 80% of the childhood cancer burden worldwide is actually in low and middle income countries. And in those settings, there's actually an increased prevalence due to the younger age distribution of the population, as well as an increasing incidence secondary to a decrease in under 5 mortality from other causes such as malnutrition and infection. So this is a growing problem worldwide. Next slide. Survival rates in low and middle income countries generally range in the 5 to about 50% range versus the 80 to 90% range that we're seeing in high income countries. And that's a real disparity. And I think what is really motivating to each of the members of the team you'll hear from today. Next slide. And so how do we address this? The approach that we've been taken is really to embrace the ideas around global cancer care that have been pushed through our national and international Oncology Consortium. So people should expect accessible, high quality cancer care for treatable and preventable cancers. That care should be affordable. Poverty shouldn't be a barrier to care. For many in this world, this will mean that care might be free. And efforts should aim to develop and strengthen in-country capacity for all aspects of cancer care and for this full spectrum of cancer specialists. Next slide. It's been shown very nicely in the literature that country income actually correlates with cancer outcomes. Next. And if you look in particular, at the time this study was done, Vietnam was really at the bottom of the 5-year survival rates for patients with cancer. Next. So I was extremely fortunate in 2016 to be part of a team that also includes Cha Chasanasan from the University of Texas. And you'll recognize Anya Agrawal, who will be speaking shortly, and then Bao Trong, who was one of our former pediatric residents here at UCSF. And we were able to do a needs assessment in Vietnam. And we took the approach based on what is done in the Children's Oncology Group, where there's a national consortium of cancer centers and pediatric cancer specialists who care for kids with cancer. And so took a similar approach and visited the majority of centers during this trip that provide care to children with cancer. So we went to several sites in Ho Chi Minh, the main hospital in Hue, and also went to Hanoi. Next slide. And during this trip, needs assessment, we identified, it's coming slowly. Can you click again? There we go. Wow, interesting. In this needs assessment, we recognized a number of challenges as well as a number of opportunities. There was a large number of children with cancer, which meant we had an opportunity for significant impact. The staff was overwhelmed and the infrastructure was quite limited. Nurses would rotate about every 4 weeks, so there was no consistent care. However, there was a very talented pool of both physicians, nurses, and pharmacists, surgeons that wanted to make a difference for these kids. There was no mechanism to train pediatric oncologists and a real lack of mentorship. But we had the good fortune of an international network with proven models and experience. There was a lack of clinical data and research, which really represented an opportunity to establish a collaborative group within Vietnam and a cancer registry, and also a misconception of hopeless terminal illness. And that I think represents an opportunity for building local support from the community and from the government. This is a picture of the ward at City Children's Hospital number 2. It was a fairly quiet day with only 183 patients on the Heme Onc ward. I think it's notable that they only have 120 beds, and so it's generally quite crowded there. Next slide. So what is global cancer medicine? The challenge is not knowing what the best treatment for a particular patient is, or even what it should be considered a local resource constraints. It's really figuring out how to safely, effectively, and sustainably deliver high quality, reliable care in the context of a healthcare infrastructure and environmental factors, human capacity, and patient poverty, water, food, or transportation challenges. So it's really addressing the needs of the individuals in country, and particularly the children and their families with cancer. And so I'm going to hand it over to Anu, who's been my partner through all of this, who is going to delve more into how we are addressing this, and in particular, how we are thinking about it in the context of bone marrow transplant.
Thanks, Michelle, and thanks everybody for joining our discussion today. And as Soheil had alluded to, we've kind of taken a very iterative approach to our work in Vietnam since we started, Michelle and I, in 2016. And as we've had additional collaborators join on board, and one of the things that we were really focused on was trying to be very inclusive. I think what we found in our work and with others is that a lot of the programs tend to be pretty insular, and they want to do things a certain way and only have their group involved. But given our limited bandwidth in part, we were very interested in collaborating with national, international colleagues. And to that end, we decided that it was important for us to form a NGO, a non-governmental organization, which we titled CFO, Southeast Asian Pediatric Hematology Oncology. And part of the reason that we did this is that each institution has their own constraints, and it became clear that it was going to be difficult to work just directly through the institutions. And by having an NGO, it might give us a little bit of independence. For example, we've been having data managers at each of the children's hospitals, and that's required a MOU, memorandum of understanding, between each children's hospital, each university here, as well as St. Jude's, who's provided us the basic database. So it's quite a complicated process. So having an NGO is sometimes an easier way to be able to work collaboratively. So that was one of the things that we did early on, and I think we started this in 2017. And really similarly to what Michelle described, it was really important for us to think about continuous collaborative research and quality improvement with the ultimate goal of improving outcomes for children with cancer and blood diseases. You can go to the next slide. So taking a little bit more from Dr. Schulman, implementation science, I think, is a really, really important way to think about how to make improvements in the global setting. I think of it as kind of an iterative quality improvement project that you have a hypothesis, just like any other scientific method, and then you continue to try to improve outcomes based on these hypotheses. So for us initially, how did we think about improving cancer outcomes in Vietnam? We had to have some specific methodology to do that. And so for cancer, we decided to start a training program, develop a database, data managers, try to develop unified treatment protocols. So that was some of the first iterative things that we've gone through, and we've talked about that in prior years in this setting. And so we've kind of taken an iterative approach to each of these projects, and we've thought about each of them in their own compartments, because there's so many different things that you can do. So it's important to try to take it stepwise and take one piece at a time, because otherwise it can be pretty overwhelming. And I think the other nice thing by doing that is that we could find collaborators in each of these different areas. And so with oncology, data management, et cetera, we've had different partners who've helped us with the training program. We've partnered with the university in Ho Chi Minh City. So in that way, we've been able to have a different idea of implementation science for each of these aspects. And that's what we're going to talk about today further in terms of bone marrow transplant. So I think the other part that we really tried to view to our colleagues in Vietnam is this is important, of course, because we want to improve care for the patients there. But it's also really important for them to help in terms of developing scientific method to be able to understand what the baseline incidence is, what the outcomes are for patients, how to improve upon that, and that we can provide these treatments safely. Because I think many people in Vietnam, most still probably believe that pediatric cancer is a life-ending disease. And so it's important to be able to show with time that in country they are able to improve the outcomes, because ultimately the sustainability of these programs is based on not only in-country support, but also then developing local fundraising. And that's been a really important part of other programs that have been successful. So through implementation science and an iterative approach and having underlying data, you can hopefully show that you're improving outcomes. And that's very attractive for funders who want to be part of that process. So really for us, it's been how do we identify the gaps and make improvements in those areas? And as I alluded to initially, we saw, as Michelle had said too, in 2016, there was multiple gaps. So infrastructure was a large gap, not one that we could necessarily fix. That's something that fortunately the country has been really focused on fixing. They built a new children's hospital, City Children's in Ho Chi Minh City, and that's been growing and getting bigger. And they have many additional ideas for infrastructure improvement. And similarly, that's allowed them in some ways to be able to consider doing bone marrow transplant because you need a very, very specific infrastructure to be able to do that. And so initially, our focuses were on developing expertise in pediatric hematology and oncology, as well as treating those diseases. And then as we've taken an iterative approach, one of the additional gaps that we've seen and why we've started this part of our project is that there is a strong desire to do bone marrow transplant there, but again, there's really a lack of expertise to be able to do that. So as Michelle had shown in the prior slide, there's often this push-pull because from our standpoint, we would say, whoa, wait, you're not ready to do this. This is very difficult. And, maybe we should focus on just, first under 5 mortality. And when you figure that out, then maybe trying to do pediatric oncology, but bone marrow transplant, you're not quite ready for that. But respecting what they want to do, they really want to be able to provide care at the same level as in high income settings. And being a middle income country, they're moving very rapidly to that. And so we respect that that's their desire. And it's our job to try to sort out how can we help them reach that and how to help them overcome the gaps to be able to do it successfully. So I'm going to talk a little bit about what the current situation is there in terms of pediatric bone marrow transplant. And then I'm going to turn it over to Sang after that to talk a little bit more about that. Sang is a pediatric resident at UCSF who's from Vietnam and really interested in helping to improve outcomes there. And it's been really instrumental in this part of the program. And then after that, Nancy and Linda, who are both BMT specialists. Linda spent a lot of time working internationally and has done an amazing amount of work in many settings to improve nursing, both curriculum and teaching, is very involved in SIOP as well, which is the International Society for Pediatric Hemonc, and has done a lot of work in Vietnam as well. I think one of the things that Chach started doing initially when he started work in Vietnam in 2011 was to try to break down silos by having visitors come and spend time at UT San Antonio. And initially that was the silos just between the different hospitals, but now that's now the silos between the nurses and the physicians, which is very common in low and middle income settings. It's a very hierarchical structure where the doctors dictate what is to be done. And we've really tried to imbue to the nurses to become advocates for the patients. And if they feel like information is not being appropriately given to the families, or if they're worried about something, that they can really advocate for the families just like nurses do here. So historically, the approach to low and middle income settings has been a twinning approach, and this has been very, very successful. This was initially really pioneered by St. Jude in South and Central America. And the approach with the twinning program is you choose a single place or a single hospital, and you put in a lot of resources there to try to improve outcomes. And the first place that St. Jude's did this was in Recife, Brazil in the 80s and 90s. And so initially they collected data that was really important. How many patients were abandoning treatment, how many were relapsing, and then how many were dying, and what was the event-free survival. And so then subsequently, they brought in training. So they trained the local staff, and then they developed a treatment protocol that was appropriate for the setting. So not an intensive regimen like we would do here, but something that would be more feasible in their setting, given the level of supportive care they have, as well as the medications they have. And so you can see very rapidly by implementation of resources, you could rapidly drop abandonment of treatment. So the families could see the potential benefits of staying on treatment. Relapse is decreased. And then, of course, you're adding in a more intensive treatment protocol. So initially there's more toxic side effects, but as you improve the training and the infrastructure and the supportive care, you're able to decrease those while having continual event-free survival improvements. So not only does it show the benefit of a twinning program, but I think even more importantly, it shows how important it is to have data, because if you're trying to get a funder and you're able to show this kind of data, this is a project they would be much more interested in joining. And I'm sure in this iterative approach, they used implementation science at each step to be able to continue to look at what are the gaps, how do we continue to have incremental improvement over time. Where we've come now is more of a regional twinning approach, where you no longer think about a single hospital and twin with that, but you try to twin with the region with the same principles, where you look at the gaps, you develop local training, you develop local expertise, and you develop, again, unified treatment protocols. And again, St. Jude's really been the pioneer in this for pediatric oncology. In Central America, they helped to create a HOPCA, which is a Pediatric Hem-Onc Association, not dissimilar to what we have here in the United States with Children's Oncology Group. And they were smart, so they took an iterative approach. They took one oncology diagnosis at a time. They started with Burkitt's because the treatment is relatively straightforward with Burkitt. Doesn't require a lot of medications. It's relatively cheap. It's a relatively short treatment protocol. And then iteratively, they started treating other diseases with an iterative approach. And similarly, they started with 1 or 2 countries and then expanded to the entire region. And that's been a really successful model. And they've had many oncologists that have gone to St. Jude and trained and then gone back to their home countries and now are the local experts. So this was, for us, was a really good model for Vietnam. If you look at, we'll show you the map of Vietnam, it's very similar as far as size, as well as population as the Central America region. And so we wanted to use the same regional twinning approaches with the background of implementation science. So I really like this slide. This was from a while ago. It's a really nice slide, except there's a single typo. But anyway, it's a nice slide just to show that there's a lot of pieces to be able to improve outcomes, especially when you start to deal with more complex diseases. And so, I think it's very important to do a needs assessment and say, is this place ready to be able to do this kind of work? I worked in Ethiopia for a little while, and it was pretty clear that they weren't really ready, although things have improved since I was there over a decade ago. And so I think Vietnam, when we were there, was clearly on the cusp of being able to do an amazing job with pediatric oncology. They'd really overcome under 5 mortality. They had the infrastructure, as I mentioned. They had the pediatric training. So they were really ready to start to work on improvements in pediatric subspecialty diseases. And so here's the map of Vietnam. It's 3 main regions: the north, which is centered in Hanoi, the central region, which is centered in Hue, and then the south, which is centered in Ho Chi Minh City. And there are 13 main childhood cancer centers in Vietnam, spread between those 3 regions. And we've been fortunate to partner with most of these hospitals, which has been a really, really good process that started initially with Chach going there and developing relationships and developing trust, which takes a long time. And that's been a really important foundation for us to be able to continue to do increasing work there in partnership with our colleagues there. And then as far as bone marrow transplant, the centers that are bordered in red here, 5 centers are performing bone marrow transplant. And then the ones that have the dotted red box are the ones that are in the process of starting to do bone marrow transplant. So there has been a history of doing bone marrow transplant, and the Ministry of Health, who we don't have a lot of access to, fortunately, in a communist country, which I think has been one hard challenge for us, they kind of dictate some of these things, and then the centers have to respond. So it doesn't always make sense to us, but we just try to help as possible. So the last slide for me, I just wanted to show where each center is and where they started. So here's for us, when we started to think about how do we help them from a bone marrow transplant standpoint, we identified at each of the centers who is the lead physician and nurse that can be the point person in terms of developing improvement in process, which Sang and Linda and Nancy will talk about in terms of their bone marrow transplant approach and hopefully that their outcomes. And so you can see here, BTH, led by Dr. Fu, had started doing transplant quite a while ago in 1995. It's a private hospital in Ho Chi Minh City. Mainly, again, a lot of these hospitals do both children and adults. And so they initially were mainly adult, but Dr. Fu is focused on pediatric bone marrow transplant. And so we see them as some of the leaders amongst the centers, given their longer expertise. Most of the centers have started with autologous transplant and then moved on to allogeneic transplant. And you can see there are other hospitals in the north as well that have been doing transplant for a while. And then the centers I mentioned, such as Hue in the central region and other centers in the south that are in the process of starting to do bone marrow transplant, again, typically with autologous transplant and then moving on to allogeneic transplant. I'll turn it over to Sang. Thanks.
Thank you so much, Anu. So when we begin this project, we actually want to see like how's like the bone marrow transplant actually doing in Vietnam. So we do a need assessment to see like how many cases so far, like see in the beginning at each different hospital, like how they doing like in terms of like different kind of like transplant and how many they're able to do so far. So as you're looking at right here, the PTS, as Anu mentioned, like since 1995, they was able to do like 58 transplant, a majority on of like the hospital able to do so far is for allogenic like transplant. However, for the most recent years, there is a shift in like new perspective of like doing transplant using like haploidentical, like basically using like the patient the bone marrow from like the parent or like the sibling. So it will be like minimize like the need of like finding like a potential match as like outside of like the family. When we're talking about haploidentical transplant for this patient, there's like also like increasing need of like chemotherapy, also the procedure protocol to reduce the risk of relapse, and also like GVHD, which will help to increasing like the quality of life of the patient. Majority of source of like the transplant so far, like they come from like peripheral like blood stem cell, and also we have like a bone marrow. Bone marrow is the second to the most also. In Vietnam, even though we don't have like a bone marrow registry to find like a particular like match within like Vietnamese community, they do have like a core blood like a blood bank store from like the beginning, and that is like associated with the PTH in the Ho Chi Minh City also. So if all the hospital they want to contact, like for example, they want to find a match or they want to find a core blood like source, they will contact like the PTH to see like whether or not like they can find a match for the patient. So when we're looking at like talking to a focus group interview in Vietnam, in Vietnamese and also English with like the Vietnamese physician, we identify like 5 different like big area of like improvement. First thing is Nancy and Linda will talk about this. We don't have like nursing training for the chemotherapy and intensive care, and a lot of things is about like for example, something very like basic we do in the US, like for example, the NG tube feeding. We don't have like a protocol to use that appropriately. So that's what we want to train like nursing in Vietnam to learn how to do that, and also like, in the future that is can be applied for other areas also. The second thing is like we don't have a centralized database and protocol, and you can see like we have like 5 different like, hospitals across in Vietnam. However, we don't have like a storage of like base to see like how which each center like which area they do the best. Maybe like in like southern Vietnam they prefer to do allogenic, so they may be more stronger in that, and on the north they more like shift forward to haploidentical. So that is like they refer to do that for different kind of like blood disease and also cancer. So that's what we want to see, like how we can centralize the protocol to share among different hospitals so they can have a similar one. And that is set up like the annually review of the protocol, so that everyone in each hospital can be updated, and then also like they can talk among each other to see what they can improve at each institution also. The third thing is about like a bone marrow registry. As I mentioned, we don't have a bone marrow registry in Vietnam. So majority of the patient, if they want to find a match, they have to go to like outside the country. Unfortunately, for those patients, the government didn't pay, like the insurance not cover for that. So if the family want to do that, they have to pay by their own pocket, and they have to go to Taiwan or Singapore or Thailand to find a potential match, and then connect with like the registry in that international country and find the way to transfer like the bone marrow or blood stem cell to come back to like the US. To come back to the Vietnam. Another thing is in Vietnam, they do have like the HLA typing. So basically original, when you identify the match, you want to see whether or not like that patient have like the HLA matching to the patient. In Vietnam, they very low coverage from the insurance to do this gap typing, and it can cost about like $500 to $700 per person per match, based on the low resolution or high resolution. So if you think a majority of the patient in Vietnam actually come from like the low income like province, so they don't have a lot of money to pay for that. So the chance of finding the match is really low also. Number 4 is about the regulation of bone marrow transplant in Vietnam. So particularly we have like the law for all the kind of like transplant, for example, like kidney transplant or solid transplant, but we don't have like something particular law for like bone marrow transplantation. So all of this like bring up like a bigger picture like in the future, if we proving the process, and also we want to establish more about how to improve like the infrastructure. We do need like to have the law to implement in the future. And the last thing, the shortage of advanced medication. So those are including like chemotherapy, also the antibiotic, including like treatment, but also the anti-phylaxis like prior to like the bone marrow transplant also. So I will pass to Nancy and Linda to talk about like how we're using like the interprofessional implementation center approach to improve bone marrow transplant in Vietnam. And I will take the last couple minutes to sum up everything we have.
Thank you, Song. I would like to move to the next slide and talk a little bit about nursing.
Oh, I'm sorry. I think I missed 2 slides.
Okay, go ahead.
Yeah. So in terms of this, we also using like a monthly meeting. So discuss with like different international faculty. So for about a year after established, we identify like different kind of area, like the in-country physician want to discuss. So for you, as you can see right here, like we have like people, physician from Chile, from Italy, from like Florida, and also Linda and Nancy also give like the lecture about like NG2 feeding also. And at the last couple of meetings, we actually developed a protocol to implement how to use like the standard operation procedure. Basically, this is a procedure like UCSF using similar with other hospital in the US. So we want to giving that opportunity to translate the protocol to Vietnamese, and then we can discuss among like the physician in Vietnam, and we choosing the PTS as a model first to use this protocol, and from there they will say which area they can do that like feasible in Vietnam and which one is they cannot do, and then they will distribute that protocol among other hospitals. And now I will send to nursing skill for Linda and Nancy. Yeah.
Okay, thank you, Song. I would like to talk, and then Nancy will join me in a few minutes, about nursing role in pediatric oncology. Next slide, or next, yeah, thank you. Pediatric oncology is a subspecialty which requires specialized education and skills. It requires adequate resources as well as leadership. And all of this is to provide optimal patient outcomes. It is really necessary to have expert and high quality nursing care in order for any pediatric oncology or transplant program to function. And Nancy and I are going to talk a little bit about how that has occurred over time in Vietnam. Next slide. I want to share with you a little bit of evidence-based practice looking at the impact of nursing on patient outcomes. Research has been done by Akins et al. Over the years, looking at the impact of nurse and patient ratios on patient outcomes, positive patient outcomes, looking at the practice environment and nursing education levels. All of these things have improved outcomes for our patients and the quality of care that we provide. In patient environment, we're not looking just at the physical environment, but also how do teams communicate with each other, physicians, nurses, pharmacists, to provide the best care possible for patients. Next slide. I was been involved, as Anu mentioned, in an organization, SIOP, International Society of Pediatric Oncology, for many years. And I was fortunate enough to be part of a group in 2012 that met with nurses globally from low, middle, and high income countries. And we began to look at the challenges for nurses that all of us faced in our countries, and particularly in low, middle income countries. And we were able to publish in Lancet in 2014 the 6 baseline standards. And they're really important because they've served, at least for myself and other nurses who've worked in Vietnam, the foundation of how we have modeled care, staffing based on acuity. And as Michelle mentioned, retention. If you train nurses and they rotate out of the unit within 1 to 2 months, you're constantly retraining. So it's staffing, retention is critical. Formalized orientation, as well as ongoing education, multidisciplinary teamwork, resources for safe care. And that includes looking at providing chemotherapy safely, dealing with isolation, infection control issues. And then finally, evidence-based practice are areas that continue to be addressed. We've had 8 publications over the last almost 10 years related to the baseline standards, and we continue to really push this globally and within Vietnam. Next slide. I wanted to give you a the slides are cut off a little bit. I wanted to give you a pre-COVID snippet of some of the activities when we were doing our visits to Vietnam. And this is a team of nurses as well as a psychosocial teammate from Texas that is in this slide and part of the visits. But we, in 1 year, made 11 visits at 6 hospitals. We gave over 40 presentations, had interactive groups, and you could see some of the topics that we had presented that year. In addition to that, I have really supported nurses to attend not only an annual conference within the country that was created in, I think, 2018, along with the physician conference, but also to be able to submit abstracts and attend SIOP. One of the challenges Nancy is going to talk about, that English is not spoken by most Vietnamese nurses. So our visits can be very challenging because we require translation for all of our presentations and most of our interactions. So next slide. Over this time, we have really been fortunate to develop close relationships. This is my leadership group that has developed over the years and represents directors of nursing, nurse managers, senior clinical nurses, and it represents about 6-7 hospitals. And these nurses were working in isolation. And one of the things that I felt has been a great accomplishment is putting them together so they can together collaborate and use their own resources to provide the best care possible for patients, as well as resources that the international mentors bring. And I think that brings sustainability to programs. And throughout this process, it's really important to have cultural awareness in order to maintain what is unique to Vietnam and not, overshadow what we believe is the right thing to do at all times. Next slide. So with COVID, we've really had to change how we've done things, and the nurses have been very receptive to ongoing educational programs by Zoom and have committed to a monthly meeting. It is 8 p.m. in Vietnam, and as was mentioned previous, many of the areas of content were of interest, particular chemotherapy. So we ran a 4-course chemotherapy session, and this was attended by over 100 nurses. So again, with our initial assessment with chemotherapy being a hot topic, this really showed to be an area that was needed for the nurses there. I think the other thing I just want to mention about chemotherapy and the baseline standards, along with myself, Anu, Chach, and Michelle, we advocated for safe environment, safe care, which is part of the 5th standard, and that includes pharmacy mixing chemotherapy. And during our visits, we all addressed this issue. So hospitals that were mixing chemotherapy in the middle of the unit have slowly moved to having pharmacy mixed chemotherapy. And that is a huge step. And many countries struggle with this that I've worked in that have not done this. So Vietnam has been very receptive to many of the suggestions we made. Michelle mentioned retention. One of the largest hospitals there rotated nurses every 6 months. And we have been able to educate the director of nursing, and this behavior or practice had stopped. And I'm just really, those are the little things that make me really thrilled to have been part of this project. So I'm going to turn it over to Nancy, who'll talk more specifically about transplant. Nancy and I have been colleagues, clinical nurse specialists for 30 years. And I felt that her expertise in transplant really would add to this project. So I'm going to turn it over to my colleague.
Oh, Nancy, you're on mute.
Yeah, you're mute.
I always do that. Good morning, and Linda, thank you for the lovely introduction. I must say I'm thrilled to be here, and I am officially the newbie of the group, so I'm learning as we go forward, but I'm very happy to be here. So what I'd like to do is talk a little more specifically about some of the things that Linda has given you background and information on. And as the slide demonstrates, okay, they've built a great baseline, a great foundation with the oncology program. Now, where do we go for stem cell transplant? Because clearly that can be a more complex caregiving environment for not only the physicians and the nurses, but for the patients as well. So in fall of 2020, I was invited to participate in this expanding work described by my colleagues today. How do we move forward? How do we translate prior experience, prior successes into a new collaborative model? So next slide, please. So in developing the nursing task force, what we did is we worked within the guise of the larger physician-based task force. As an outgrowth of that meeting, Linda was able to coordinate, seek out and coordinate interest from nursing staff in the varying centers. And it was really important that, that we elicit participation by nurses that were not only vetted by the nursing hierarchy in their institutions, so they had some legitimacy to move forward with planning, but also by their physician partners, because we all know that physicians can do work and nurses can do work, but when we team up together, we can exponentially impact the amount of work that we collaboratively provide. So once we were able to set up that initial meeting, I think there were at least 18 participants for Vietnam, including some nurse consultants from Singapore, Linda and myself from the US, and administrative support from Australia, and a general supporter from Japan. So it was clearly a worldwide endeavor at this first meeting focused on stem cell transplant nursing. And that was in the winter, like around November of 2020. The Vietnamese nurses involved clearly identified that they wanted education and they wanted to develop clinical expertise within the realm of transplant. They knew that they needed more information and they were able to articulate what areas, and they were very clear that they knew they needed more. They weren't exactly sure what the content area was, particular areas, but they were very clear about it. And one of the things that impacted me at that moment was that because all these meetings were translated, Linda would throw out a question or a comment, tell me about what particularly do you want to know about intra-transplant care? And although these nurses had been very quiet up until that point, you would see 18 screens light up with numerous voices and all this head shaking. And it was amazing to watch. And it was so frustrating at the same time because I think my Vietnamese is about 2 words, and that's on a good day. So we really relied on the translators to be able to help us understand what was going on. It was so impressive that it was very similar to my experiences in the US, where you throw out a hot topic or a controversial topic, and all these nurses who were sitting very quietly, very reserved, suddenly become just animated and want to talk and want to find out more. So one of the things that the nurses came to with some suggestions by us, they agreed that a needs assessment to be able to centralize presentations throughout the country and work in a collaborative fashion. One of the things that they agreed upon was that we should move forward with a needs assessment to really tease out how to best spend our time and energy and really focus it on what the nurses needed, and then also to develop expertise within Vietnam itself. So they didn't need to continue to consult us. They very much agreed with that would be a good way to move forward, and they're very intrigued in that. But then, unfortunately, in the spring of 2020, COVID really started to explode in Vietnam. Next slide, please. Prior to the explosion of COVID, I thought the best example and about the collaborative effort that we were working on was something that the nurses would also very much appreciate it. As part of the physician task force group, there was a lot of expressed need and discussion about enteral feeding support throughout stem cell transplant, throughout the phase of stem cell transplant. And this is definitely a physician-nurse collaborative approach because, and also with nutrition support as well, you need a team effort to be able to look at nutritional needs, address the medical needs, and then also address the day-to-day management of the equipment and the mechanics and the tolerance of the feedings. So Linda and myself were able to use slide decks that were shared from our colleagues and a review of evidence-based literature and prepared a presentation that we then met with a physician and nurse pair from Vietnam to tease through and say, so tell us about your practice a little bit more. How do you handle specific instances? What kind of nutrition support do you use? Do you use prepared formulas? Do you use prepared soup from families' homes? How do you address these kinds of things? So with a couple of preparation meetings, we were able to finalize a slide deck. And then we floated with the Vietnamese staff that we thought it would be a good idea if they would like to present this, again, to establish some level of expertise and reference within their own community. And the physician-nurse pair decided that the nurse would do the presentation. And not only would the physician task force be involved to participate, but we would open it up to nurses and dietitian staff as well. And so that was presented, and it seemed like everyone was very pleased, not only with the content, but the style of approach, and that it was an interdisciplinary approach discussing transplant care. Go ahead, next slide, please. Oh, I should add as well that one of the key components was it was presented in Vietnamese with simultaneous translation into English. And then before the presentation, we shared both an English and a Vietnamese slide deck. So it was really critical to make sure that everyone was covered so that they could have a firsthand look and understanding of the information presented. Next slide, please. Oh, there we go. Sorry, I think I went 1, 2. Okay. So challenges, as I've alluded to along the way, we need to make sure that you start with key stakeholders that are recognized by their colleagues as well as the institution. And that's really critical because as COVID approached, what happened was that many of the key stakeholders were reassigned either away from transplant or their extra time was focused on the COVID pandemic. So people no longer had the time. And frankly, even if they wanted to work on these kinds of projects on their own time, they had no energy left because they were just overwhelmed with the COVID pandemic, as many of us have been throughout the last year and a half. Again, another key challenge and key component, translation is key. Many of the nurses have some element of understanding of English. They have difficulty expressing themselves in English. And again, my Vietnamese, Linda's Vietnamese, is not really good, but there have been tremendous efforts to secure stellar translation for us and allow us the ability to have not only focused conversations, but to understanding more of the cultural influences that influence nursing care. Flexibility with preparation, with meeting planning is also key. It may be 6 a.m. for us in the States and 9 p.m. or 8 p.m. in Vietnam, and then everywhere in between. So again, flexibility and willingness to work along with that is key. And so where do we go from here? How do we move forward? Well, COVID has clearly put a slowing, almost a complete halt to our efforts. However, there seems to be continued commitment that just give us a little more time and we can get there. We need to deal with what's on our plate in front of us before we can grow. And that is a very valid observation and one that definitely must be respected because we've all experienced that here. Many of us are fatigued and do not have the extra time or energy to move forward with collaborative international products. Although we still want to do these projects, it is very taxing at this time. However, the silver lining to that is that we've been able to establish relationships and recently received an email from one of the physicians in Vietnam. They wanted some consultation about skincare, enteral feedings, and then also they were using a preparative regimen for transplant that was novel to them in their sending. So they reached out and said, we have information about this, but can you share your experiences to help us anticipate? And that felt like a huge triumph because they trusted us to ask a novice question and felt like that they would get support. So next slide, please. You cannot provide any kind of talk or any kind of work like this without acknowledging your colleagues. The list is numerous here, but a heartfelt thanks to all of them and to my mentors in this process as well. Thank you so much.
So for the last part, I will talk about like one key thing that we identify about like the HLA typing and also like the bone marrow registry in Vietnam and how we target this problem. So by contacting with like a international like registry like the BMTCN in the US and also the DKMS, this is the registry based in Germany. So with this both like registry, we thinking like even though we don't have like any data from HLA in Vietnam, however, like a lot of Vietnamese people with the ancestry Vietnamese already like registered for those of like this like register. So we want to use their data to analyze what is the most frequent like HLA typing to help like to build up a lower cost HLA in Vietnam. The other thing is we working with like the DKMS right now to help. Hopefully we can send a sample from Vietnam to the Germany for typing for free to collaborate with their project in the beta thalassemia transplant also. So, and last thing is like the goal, the biggest goal is we want to identify like the site of bone marrow registry if we want to present this information to the Ministry of Health. So hopefully we can have a sustainable program in Vietnam, and potentially we can bring up like a mechanism to provide lower cost for HLA typing. So this is like the project, like our team is still regroup. People to join. The first one is like, as like Nancy and Linda mentioned, there's a lot of like key thing about like translational teams. So we hope to develop a Vietnamese translational team to help with like the project. The other thing is like we on like the process of writing the IRB to looking at the mixed study for qualitative and also quantitative, to looking at the impact of this bone marrow consortium. So there's my information downstairs, and also Michelle. So if you get interest to join any of the project, like feel free to contact us. Just to summarize, I hope like we demonstrate to you guys like how we using implementation science approach to target like different gap in the bone marrow transplant in Vietnam, from the nursing perspective, also chemotherapy, from like HLA typing, and the biggest goal in the future, like we can provide a centralized protocol and database for Vietnamese, and the final, like the biggest of the biggest, like improve the quality of life for the patient go under the bone marrow transplant for pediatric population in Vietnam. So we would like to thank all of the collaborators. We cannot do this without a village. So it's gonna take a village for many, like, multiple years continue to help this process move forward also. And here is on of like the funding and also like collaborator international on of like the organization to support like our work also. And now we can take a question. Thank you so much for listen to us.
Thank you everyone for presenting. If you guys have any questions, please feel free to unmute yourself and ask, or you guys can ask it in the chat box. And if everyone can just please take a few minutes to fill out a survey, which I'll be sending in the chat, that'd be great.
It looks like Annette has her hand raised.
Yeah, feel free to ask your question, Annette. Thanks.
Okay, hi everyone. Thank you very much for your presentation. It's been a long time since I lived in Vietnam, but I did for my K grant research on pediatric HIV. And one of the challenges that we had during that time was when we trained HIV nurses, they often felt that they were upskilled and they had the opportunity to move to private hospitals to get better pay than what they were getting at Children's Hospital 1 or Children's Hospital 2. So I'm curious if you've experienced that, not from being rotated off service, but from brain drain.
Actually, that's interesting because I have not experienced it. One of the best things for me is over the last 5 years or going to Vietnam, the same staff is there. There's been an occasional change in nursing management, but the nurses have not changed. And part of it is the focus of trying people who are interested in pediatric oncology, trying to keep them there and to train other nurses and to keep them interested in going back to work in the same setting. They've established really close relationships on the unit with the physicians at some of the hospitals.